Dear colleagues, this is a hypermature cataract. Let us see how this surgery goes. The main incision has been placed at a selected site. One paracentesis incision is being placed on the right side of this main incision. These are all posterior limbal incision and it causes a little bit of oozing of blood. A big air bubble has been injected into the anterior chamber. Now trypan blue dye has been injected underneath this air bubble, but most of the air came out. The dye is washed out. Now viscoelastic substance 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. The anterior chamber gets filled up with this OVD. Now one more paracentesis incision is made on the left side of the main incision. Now the capsulorhexis is to be done. I use this 26 gauge bent cystitome to incise the capsule and see what happens. This is milky fluid. Whenever this liquefied cortex, that is milky fluid, comes out, it is a morgagnian cataract, hypermature morgagnian cataract. We gently aspirate this milky fluid with a Simcoe cannula, and viscoelastic substance is again injected into the anterior chamber. Now I take a Utrata forceps, very thin, very nice Utrata forceps. I got it from Einor, the company is no more. Very slowly a continuous curvilinear capsulorhexis is done. The intralenticular pressure is not high at this moment, and I am not afraid of running of this rhexis margin underneath the iris. So rhexis has been done, and now viscoelastic substance is injected again. We are going to use Oatly's Cataract 3 Phaco machine in this case for phaco emulsification. Here it is. The tip of the phaco handpiece is impaled into the lens matter. I go to a deeper level and I try to chop the nucleus. Yes, the nucleus is not very hard. It is of moderate hardness, and but I have to go near the equator so that I can chop it. I go near the equator, maybe 2-3 millimeter away from the equator. I stop and then I try to chop it. And this is the way. Now this is the hard core of the nucleus. I emulsify and remove it. And now these fragments are emulsified with ultrasonic energy and they are removed. In this case the phaco power was 65%. Flow rate was 45 ml per minute and vacuum was 450 mm of mercury. This is the third nuclear fragment. It is being emulsified. In this case we have to be very careful because these nuclear fragments are not supported by epinucleus. So we must take care of the fluid. If it gets over, we have to change and take a new bottle in time. In this case, the fluid got over and I came out in time, injected visco again, and again I went back. This is the last bit of nucleus. It is emulsified and removed. Viscoelastic substance, little bit of it is now injected into the antechamber, and now I take a 23 gauge Simcoe cannula and remove these cortical matter. If you are comfortable with bimanual IA, you must continue with your instrument of comfort. Now in this case, we will see that there are some cells sticking to the posterior capsule just underneath the main incision, sub-incisional area. Say from 11 o'clock to 1 o'clock, these cells are sticking to the posterior capsule. We take the hydrodissection cannula and irrigate so that they become loose and they can be easily aspirated by bimanual or by Simcoe cannula. Now I go again and I try to polish the posterior capsule. Now I go through the side port and remove these sub-incisional cells that were sticking to the posterior capsule. That's it. Now it looks fine. The posterior capsule is clear. There are no cells. Now is the time for intraocular lens implantation. In this case, I am going to implant Acrysoft multi-piece intraocular lens. Whenever there is a multi-piece lens, I increase the incision little bit. Say 2.8 mm incision now becomes 3 mm. Now this is a B cartridge from Alcon, and this is Alcon's Acrysoft multi-piece intraocular lens. Place the lens inside the cartridge. Move the lens forward towards the tip of the cartridge, and now I place it on the injector. And now be careful. If the injector pushes the trailing haptic as it is now, I came out. I take a Sinskey hook, elevate this trailing haptic, and then I ask my assistant to push the piston forward, and then again I go. If I don't take care of this trailing haptic, then what will happen? I can break the trailing haptic. Most of the incidences of haptic break are because of not taking care of this manipulation. Now it is, the lens is being implanted. I give support of the optics so that it doesn't hit the endothelium with the chopper. And with a McPherson's forceps, I have implanted the trailing haptic in the capsular bag. That's it. Now the lens is nicely placed in the capsular bag. Acrysoft multi-piece lenses are the best ones to prevent PCO, posterior capsular opacification. Now is the time to remove the viscoelastic substance thoroughly. First I use this 23 gauge Simcoe cannula, flush the viscoelastic substance from the antechamber, and then I take Then I go behind the lens and flash this area. If you leave lot of viscoelastic substance behind the IOL, it can raise the intraocular pressure. There will be streamy corneal edema next morning. Patient will have pain in the night and you will not feel happy. So better to utilize 1 minute now and remove this viscoelastic substance thoroughly. This is the irrigating probe of bimanual IA. That's it. Now I use the aspiration probe also and use both together to clean the viscoelastic substance. Yes, it is 100% clean now. This is a view under higher magnification. That's it. We just have to hydrate the side ports now, form the antechamber and conclude the case. I believe you can be one of the best surgeons in the world. Just develop your surgical skills. Hope these videos will help you. Thank you very much for your attention.